Red Lano, Red Latinoamericana de Neuro-Oncología.
So I was asked to speak today about brain imaging as a potential predictive biomarker for patients receiving anti-angiogenic therapy. Let me start by saying that this is a very important area of investigation. We cannot, as of today, predict using a blood marker, a tumor marker, an imaging marker, any kind of marker who will have an optimal response to a drug like bevacizumab versus those who will not have an optimal response to bevacizumab. And it very well could be that the results we're seeing from clinical trials where we're not noticing differences yet in overall survival is that we're not smart enough at this point to pick out the subgroup of patients who will benefit the most from an anti-angiogenic drug like bevacizumab. So these are the criteria that we have historically used in neuro-oncology to define response in a clinical trial or even in the clinic. And these are really based upon response criteria from other types of solid tumors. But you can see that these so-called McDonald criteria really are focused on contrast-enhancing tumors. And in the era of anti-VEGF therapy, these criteria are really insufficient for determining response in the clinic or in clinical trials. And that is because of this phenomenon known as pseudo-response. So in the following slide, you see a patient here with a recurrent right temporal glioblastoma who is treated as part of a clinical trial, in this case, cediranib, but you see this very similar cases with bevacizumab. And 4 months later, here's the contrast-enhanced MRI. So by McDonald criteria, this is at a minimum a partial response. It's pretty close to a complete response. The problem here is that there's clinical deterioration between here and here. So between the enrollment on the trial and having this scan that by contrast enhancement is a partial response, the patient has a progressive hemiparesis. And I think you can appreciate even on the T1 imaging that there's compression of the cerebral peduncle on this post-treatment scan that was not present prior to treatment. And this is the problem. When VEGF was discovered in 1983, the original name actually in the paper for this molecule was vascular permeability factor, or VPF. And we know that VEGF results in the formation of this very abnormal vascular network that I reviewed in an earlier talk, and that this vascular network is hyperpermeable, leaky, and is why there is a disrupted blood-brain barrier. Now, it's quite logical then, if we target vascular permeability factor, that we're going to reduce permeability. So the post-contrast CT and MRI scans demonstrate reduced contrast leakage and less so-called quote-unquote tumor based on the old criteria, based on contrast enhanced. But we all know that these responses that can occur within 24 hours after a dose of bevacizumab or another anti-VEGF cannot be anti-tumor responses. So reduced contrast enhancement does not equate with tumor progression, or regression, I should say, and that tumor response criteria that rely on contrast enhancement really are problematic for assessment of anti-VEGF therapeutics. So back to the case. So I didn't tell you about these two scans. So these are acquired at the same time. So this is a T2 flare MRI, and this is an MRI that is set up to look at vascular permeability. The factor, there's a marker called K-trans, and in this paradigm, the very bright orange-yellow regions are regions of increased permeability. And you can see that over time, you have reduced contrast enhancement on this anti-VEGF agent. You have reduced permeability, but in the middle panel, you can see that there's extensive progression of T2 flare hyperintensity. And one interpretation of this this is not edema, but this is infiltrating tumor. And you can better appreciate this compression of the midbrain and cerebral peduncle, which was leading to this patient having progressive hemiparesis. So it points out the weakness of our historical response criteria in grading outcomes with anti-VEGF therapeutics, and it led to these criteria, which are now known as the RANO criteria, or the revised assessment criteria in neuro-oncology. And the big difference between these criteria and the McDonald criteria is this, that with the RANO criteria, one is allowed to declare progressive disease if there is only increased T2 flare signal abnormality. So that case I just showed you could be called progressive disease using RANO, whereas that was not the case with McDonald. Now, the problem with this to date is that these are consensus-based expert guidelines. They're not validated. Moreover, the increase in T2 flare is in the eyes of the beholder. There's no quantitative cutoff for this. So it's really left to the individual examining the scan to determine whether this increase in T2 flare is significant or not. So it's an imperfect system. It's a step ahead of where we were, but it still remains an imperfect system. And at the end of this, I'll come back and talk about some work we're doing around diffusion MRI, where there may be an opportunity there to use diffusion MRI to declare progressive disease. Okay, so with that as the précis, this is, I want to talk a little bit about some work we're doing around imaging markers of response to anti-VEGF therapies. And I come back to this notion of vascular or vessel normalization, again, hypothesis of Rakesh Jain, and I just want to dive into the weeds a little bit with this because it's important for some of the imaging I'm going to show you. So the basic idea here is that in a tumor, you have a preponderance of pro-angiogenic factors versus anti-angiogenic factors, VEGF, et cetera. And the tumor forms this very abnormal vascular network. The vessels are dilated, they're disorganized, the vessels are leaky. This leads to increased interstitial pressure within the tumor. It leads to inefficient delivery of oxygen, which leads to enhanced hypoxia within the tumor, and it might actually impair the delivery of concurrently administered drugs to the tumor. Well, the idea here is that with anti-angiogenic therapy, you bring these forces into balance, and the vessels begin to change morphologically and physiologically, and they begin to approximate what you see in a normal organ with inflow, arterial inflow, venous outflow, vessel diameter decreases, permeability drops, hypoxia is mitigated, there's better oxygen inflow. And there is, in some models, including a recent paper looking at temozolomide in an animal model, there's better temozolomide or chemotherapy delivery throughout the tumor. However, if you continue these anti-VEGF agents, you reach this situation, which is the kind of the Judah-Folkman hypothesis, that you have a preponderance now of anti-angiogenic factors, and this leads to vessel pruning, endothelial cell death, tumor starvation, etc. But it's clear that in animal models and now in human models that there is this transition period from this abnormal vascular network through a window of normalization to this more classical notion of vessel pruning. We have observed this in glioblastoma, both in preclinical xenograft models where you can give an anti-VEGF, in this case a murine anti-VEGF antibody. You see the vessel diameter drop, you see vessel density drop, you see improved pericyte coverage to something that approximates normal. These abnormally thickened basement membranes begin to thin out, and permeability drops. These are reversible, however, so there is this normalization window in these mouse models. We have also observed in humans some features that are also consistent with vessel normalization. Using MRI techniques, we see vessel diameter to drop. Using K-trans and other MRI techniques, you see permeability go down. Again, these changes are reversible. So there appears to be, in a subset, the majority, in a subset, though, of patients who receive an anti-VEGF agent like cediranib, like bevacizumab, there is this transient window of vessel normalization. So our hypothesis was that this was a good thing. This was a positive development, and that vessel normalization can enhance the therapeutic value of concurrently administered radiation or chemotherapy, potentially even increase the anti-tumor immunity. And so we looked at some markers of vessel normalization to see if they would predict outcomes in recurrent glioblastoma patients treated with, in this case, cediranib. One of the things I mentioned earlier is that in our models, animal models, you see these abnormally thickened basement membranes that after you give an anti-VEGF agent, they thin out. One of the consequences of this is that collagen 4 is mobilized from these abnormally thickened membranes and circulates. So concurrent with this drop in basement membrane thickness, you see a spike in circulating collagen 4 levels in the blood. Very easy thing to measure. So in our human trial of 31 patients, we looked at collagen 4 levels. We looked at collagen 4 levels before cediranib and 1 day after cediranib. We looked at K-trans, which is a marker of permeability, 1 day before cediranib, 1 day after cediranib. And finally, we looked at cerebral blood volume, which in this normalization hypothesis actually should improve with better perfusion of blood into the tumor. So we looked at these pre-treatment, and we looked at them 24 hours after a single dose of cediranib, 31 patients. So this is an example of a case where there was what we called a high vessel normalization index. In other words, there was a steep drop-off in K-trans, a spike in blood collagen 4, and an increase in cerebral blood volume. This is a patient who had a median survival, who had a survival of over 500 days. Here's a patient unresponsive to cediranib. No drop in K-trans, cerebral blood volume about the same, so a low vessel normalization index. This patient was off the trial and had a survival of less than 90 days. Now, when you looked at the quartiles of these 31 patients, and I'll be the first to confess this is a small study, we need to replicate this in a larger setting. But if you look at the quartiles in these, you see that those patients who had the highest VNI, or vessel normalization index, had the best progression-free survival and overall survival. So vessel normalization is definitely a marker that we feel is promising and could be looked at in future trials. I think one of the big challenges in looking at imaging markers of like this is that when you go from a single center to the setting of a randomized trial, which is needed to validate these markers, it's very difficult to replicate the imaging conditions across various institutions due to various software and hardware problems. But those things are getting better, and hopefully we'll be able to look at something like VNI across a larger number of centers in the context of a clinical trial. So that's vessel normalization index. Another marker that we are interested in, and another consequence of vessel normalization, is that perfusion within the tumor increases. So this is a paradigm where we look at dynamic susceptibility contrast MRI, or DSC MRI, and we can look at flow and perfusion in microvessels. Here's an example. In this paradigm, brightness is increased perfusion. You can see that perfusion goes up in this particular case, even though contrast enhancement goes down. And here's a case where perfusion actually drops over time. No bright signal, kind of a black vortex there. And if you look at this, and this is a clinical trial that we ran. In this case, it was a newly diagnosed glioblastoma setting in Boston. And in this study, we obtained weekly MRIs during the 6 weeks of combined temozolomide and radiation. We also collected blood markers, etc. And we have 40 cases where we looked at perfusion, all of the patients in the phase 2 study. And there are 3 populations that you actually see. You see a group of patients where perfusion goes up, their vessels are normalized, and this actually stays up for 2 months here. Then there's another group where there's absolutely no change in perfusion, and then there's a third group where there's actually a drop in perfusion over time, where there is no vessel normalization. And interestingly, if you look at the outcomes in these 3 different groups, here's the newly diagnosed setting, increased perfusion, decreased perfusion. Those patients who had improved perfusion had improved overall survival. That's in the newly diagnosed setting. We've also looked at this and published this in the recurrent glioblastoma setting. We see the same 3 populations, increased perfusion, no change, drop. and those patients who have the increased perfusion have longest survival. There was an abstract at ASCO last month from a group that looked at this for bevacizumab in recurrent glioblastoma and observed exactly the same thing. Those patients who had improved perfusion had improved overall survival. So we feel, again, that's a very promising predictive imaging marker, but again would need to be studied in a larger context in the multi-center setting. Now, coming back to the MRI I showed you earlier, where we saw a patient who had decreased contrast enhancement but clinical deterioration, and then there was this progressive T2 flare change, which I think in that particular case we would all agree looked like expansion of tumor. But again, that is a subjective call. Even with the Rano criteria, defining progression by T2 flare is in the eyes of the beholder. So we've been interested in other kinds of MRI techniques to predict progression. And this was my colleague Elizabeth Gerstner, who looked at diffusion MRI as a potential marker of tumor progression after anti-VEGF therapy. So the idea here is that, of course, diffusion MRI measures water diffusivity. And where there is, this has been shown in animals and in humans, where there is increased tumor density, tumor cell density, or tumor cell infiltration, the water is squeezed out of those regions, and so there's restricted diffusion within those regions of tumor. So she simply looked at regions of restricted diffusion over time in patients treated with an anti-VEGF drug. So here's an example of a patient with this is a diffusion MRI, this is contrast-enhanced MRI, this is T2 flare. And what you can see here is some reduction in contrast enhancement over time, but in this paradigm, blue and red are regions of restricted diffusion. You can see that these regions increase steadily over time. And when we looked at all 31 patients on this recurrent glioblastoma trial, you can see that while there is improvement in contrast enhancement, which is this bar, it drops and goes down, these regions of restricted diffusion tend to go up, and these were statistically significant. Now, we cannot, in that trial of 31 cases, prove that every one of these cases were cases of infiltrating tumor, but we're gathering more and more evidence that does support this. And this was an example, this was actually a case report in the Journal of Clinical Oncology, where we had a person with a large left frontal glioblastoma. This is after treatment with bevacizumab. So this is almost a complete response. The contrast-enhancing tumor is almost completely gone. But what is new on this MRI are regions of restricted diffusion. These popped up. We continue to treat the patient. This is practically a complete response if you believe in contrast enhancement, which of course I don't. But what you do see is that these regions of restricted diffusion increased. So at this point in time, we called a timeout, and we asked one of our neurosurgeons to do something a bit unorthodox, and that is to biopsy where there's no contrast enhancement, but this region of restricted diffusion. Because this patient had also had clinical decline, increasing language difficulty. And what we found in the needle core was that it was just chocked full of high cell density glioblastoma. And of course, the patient went on to progress and ultimately developed contrast enhancement where there was progressive disease. But an example of this restricted diffusion correlating with regions of cell infiltration by tumor. We've also seen supportive data for this in a series of autopsy studies that we've done where we've been able to correlate anatomically regions on the MRI pre-mortem with regions post-mortem of tumor cell infiltration. So what are we doing right now? So we are, our most recent set of studies are looking at this, really paying close attention to this notion of increased perfusion, because now we've seen it with 2 different agents, 2 different groups, and also both in the newly diagnosed and the recurrent disease setting. So we think it might be a very promising marker. So we have a combined MRI PET facility at our institution, and we're beginning now to, we have an NIH-funded study where we're looking at hypoxia in tumors using F-MISO PET imaging and correlating that with perfusion to see do these regions of increased perfusion correlate with regions of improved oxygenation and vice versa. And there was an interesting study at ASCO a year ago, showing that in breast cancer, that areas where breast cancer patients who had a reduction of their hypoxia within their tumor had improved survival. We have yet to show this correlation in tumors, but this would be the next step to do that. Finally, there is controversy about the impact of an anti-angiogenic drug like bevacizumab on delivery of chemotherapy. The vessel normalization enthusiast would advocate or tell you that when there is vessel normalization with bevacizumab, we should see increased perfusion, increased delivery of drug into the tumor. However, there was a very small paper published in Cancer Cell last year from Europe where they looked at this in lung cancer patients receiving radiolabeled docetaxel. And in those patients, they administered the radiolabeled drug before and after bevacizumab. And they showed in their study of 10 patients that in most of those patients there was a drop in the delivery of radiolabeled docetaxel. Now, mind you, there was no information in that study on perfusion. So what we're interested in now is our radiochemistry group has radiolabeled temozolomide, and we are actually looking at the delivery of temozolomide in recurrent glioblastoma patients before and after bevacizumab to try to address this critical question in terms of the impact of anti-VEGF agents on delivery of chemotherapy, and correlate that also with some of these other markers that I would argue are very important, like perfusion. So I believe that's my last slide. Thank you very much.
Red Lano, Red Latinoamericana de Neuro-Oncología.